up to you. I shall give you all the comments. So, in this clinical case, we can discuss two main syndromes. The first one is, without any doubts, arterial hypertension because of the enlargement of blood pressure. And the second is typical pain for acute coronary syndrome. We can suspect acute coronary syndrome due to typical retrosternal pain with irradiation. The patient must be investigated by the following plan. Though acute situation is due to coronary arterial disease, we start with ECG, troponin test, and all other markers of myocardial necrosis. They are myoglobin, creatine phosphokinase, MB fraction, it is myocardial fraction, and then echocardiography with chemical blood test where liver and kidney parameters and the sugar level will be detected. We need the level of creatinine for calculating of GFR because very often coronarography must be done both by diagnostic and treating purposes. Concerning arterial hypertension, we are to see the condition and function of target organs. I have already mentioned the kidney function with creatinine and calculating GFR. Then albuminuria. And we shall see while performing echocardiography, we shall see hypertrophy of left ventricle and fundoscopy will be enough for evaluation of the condition and function of target organs. This is the answer to the 11th clinical case. Any questions, colleagues? Okay. Clinical case number 12. We can speak about gastroduodenitis with the prevalence of duodenitis and pancreatitis in this clinical case. Why is it so? Because of localization of the pain syndrome and because of the medical history with alcohol abuse. Moreover, the results of abdominal palpation. The prevalence of pancreatitis is without any doubt. In this case, it is necessary if bowel sounds are good, we can start with ultrasound investigation. Complete blood count to see the level of inflammation. ultrasound investigation will give us the condition of abdominal cavity, excess gas, fluid, the sizes of organs, and their peculiarities. For example, damage of liver, of spleen, the diameter of portal vein. If it is possible, we can visualize pancreatic gland. If bowel sounds are decreased or absent, common direct X-ray. Examination of rectal zone with glove, just to see the presence or absence of melena, black stool. Biochemical blood test. The main parameters of liver and kidney function and amylase, the pancreatic enzyme, glucose, it will be suitable to perform upper endoscopy. Helicobacter test, and if there are any peculiarities in mucus, local biopsy of the damaged zone. We also can see lipase activity in the urine due to pancreatitis. In the complete blood count, we shall see not only the signs of acute inflammation, like leukocytosis and enlargement of ESR, but some other. For example, high level of MCV because of chronic alcoholism. And we are interested in parameters responsible for bleeding, hemoglobin and hematocrit, because such pain may also be according to peptic ulcer disease in duodenal zone or in epigastric or both. This is the answer to this clinical case. Questions, colleagues? No, okay. Clinical case number 13.
Also yeah.
Yes, you are quite right. We have done it yesterday. Gastroduodenitis. You are quite right. And the common plan of investigation with complete blood count, with urine test, by the way, just name it as a complex first step investigation if it is not of high level of emergency, like in acute coronary syndrome. It must be done because there may be some peculiarities which will give you another information, additional. So upper endoscopy with biopsy and with Helicobacter test. Complete chemical blood test, and stool test for verification, if it is possible, for verification of occult blood. Okay. Number 14, please. Dyspnea,
And
I
bleeding?
suppose, yes. I suppose dyspnea is due
Bleeding?
to pain syndrome. We may suspect bleeding here. We may suspect it, yes, because of low level of blood pressure, which plan is more suitable here is upper endoscopy, complete blood count with verification of hemoglobin and hematocrit, and rectal inspection with glove to see whether if some elements of feces can be found. We can see the presence or absence of melena. Melena is a typical signs of upper gastroenterological bleeding. Yes, you're quite right that it is bleeding, and the source of it is more often, in this case, a duodenal ulcer because of such appearance of epigastric pain. It is more typical to duodenal zone, though it may be a stomach also. Okay, what is about 15 test case? So it is coronary artery disease. If it is the first episode, we can speak about first episode of angina. If it is not the first episode, we can speak about angina at effort, arterial hypertension, look at the level of blood pressure, and the heart failure, appearance of gallop rhythm. It is heart failure. What is necessary to do? In case of such situation, it is an emergency one. Cardiac enzymes or cardiac markers of myocardial necrosis must be done. Myoglobin, troponin, creatine phosphokinase, MB fraction, complete blood count, common biochemical test, and ECG, echocardiography, and the patient must be prepared for coronarography. While the patient is preparing to coronarography, we can see the function of kidneys with GFR calculation according to the creatinine level. Echocardiography will give us hypertrophy of myocard of the left ventricle. And if we are in time, we can perform fundoscopy. It is 1-2 minutes to see the vessels. Any questions, colleagues? No? Okay. So clinical case number 16. So this is the acute heart failure in the patient with medical history with hypertension and diabetes. So all the signs, dyspnea, low blood pressure, tachycardia. Moreover, she has angina attack. So it is acute heart failure due to angina attack also. Echocardiography and ECG must be done. Cardiac biomarkers, myoglobin, troponin, creatine phosphokinase, MB fraction. Biomarker of acute heart failure. It is brain natriuretic peptide, also must be done. Complete blood count, common urinary test. Chemical blood count. Echocardiography. ECG. This is the main. Colleagues, any questions? Okay. Case number 17. It is chronic heart failure with typical signs and hypertension if it is estimated. It is necessary to perform ECG, echocardiography. All the tests we have mentioned in the previous clinical case, but not of emergency block. First of all, we need brain natriuretic peptide. It is a marker for heart failure. It doesn't matter acute or chronic. If the compliance are not acute, they are chronic, it is not necessary to perform myocardial necrotic biomarkers like troponin. Just full chemical test after complete blood count. And if it is necessary, planned coronarography may be discussed. Results of the additional investigation will give us the information if it is necessary to perform coronarography. Clinical case number 18.
Acute myocardial infarction.
You're quite right. So we investigated according to the standard procedure, myocardial biomarkers of necrosis. Then echocardiography ECG is done. We just monitoring it. Full biochemical test. And the patient must be prepared for coronarography and thrombolysis. So we need the coagulogram or hemostasiogram. They are synonyms. Thrombolysis and stenting during coronarography may be performed one by one. That's why the patient must be prepared with corresponding investigations. Clinical case number 19. It is also acute myocardial infarction, hypertension, So the previous answer to the investigative plan may be used also here. Okay, and the last one, please. Case number 20. I suppose clinical case is familiar for you. We have done like this a lot. So it is acute hepatitis. The main syndromes are inflammation, cytolysis, and cholestasis. It is necessary to perform abdominal ultrasound and to monitor all laboratory tests. That will be enough, but the monitoring must be each day. Okay, colleagues, we have discussed all clinical cases that you will get at exam. Now let me tell you the procedure of the attestation on Monday at the 28th of December. Group 76 will start at 9 a.m. by Moscow time. Group 77 at 10:20. You may not mark it, just listen. I shall send you the whole information. Group 78 at 12. And all groups for summary of the attestation are welcome to a 1:45 by Moscow time. Each student will get 2 clinical cases, 10 minutes to be ready, and then answer. It will be necessary to switch on camera because the procedure will be according to the registration. It will be done in Zoom. I shall send you the links for Monday and the time of the onset of each group. According to the geographic localization, group 76 will start because they have 5 hours plus from Moscow time, and the main students of other groups are not so far, so they will start in other hours. The whole collection of the students is not so necessary. This is the time for solving of the problems if somebody is not satisfied. And next day, I mean the 29th of December, the Department of Propedeutic will put all our marks to electronic examination lists. So you will see them, I suppose, before New Year. Which questions do you have to me? No questions? Okay. So, yes, no questions. Good. You're welcome. Without any doubts, each student will get additional questions according to the topics. Don't worry, it won't be nervous. It will be extremely soft and nice. Don't worry. The third year is very difficult in um, medical institutes. That's why and we remember ourselves in the students' period. It is very difficult year, and it is not necessary to increase the level of stress for you. Okay, so though we have the last class before attestation, I would like to give you some advices how to prepare for the final ID exam in January. First of all, look at the topics that our department has sent to you, because you will answer at this department according to the topics that you have. One theoretical question, one clinical case will be at a final ID exam in January. It is necessary to refresh in your mind some ECG, especially myocardial infarction and atrial fibrillation. There are some clinical cases with ECG enclosed in them. The structure of the answer is indicated in the question, in the topic. Start with definition, please. If it is necessary, give a classification, the main clinical syndromes with sciences inside, and the plan of direct and indirect investigations. Speaking about the syndrome, please do not forget that the syndrome is a number of sciences which are connected pathogenetically. This is important to remember. For example, fever may be a sign of inflammation, but inflammation may be due to infective process like pneumonia, due to myocardial infarction, because necrosis is also an inflammation. But fever in this case will reflect different kind of inflammation. Headache may be like a migraine because of cerebral vessels dystonia, or may reflect, for example, intoxication, but it will be a headache. The sign is equal. Pathogenetically mechanism which put this sign inside different syndromes may be different. Okay, so I'll send you self-training today with video. I'll give you the opportunity to be ready to the final practical exam. You know that today for Christian persons it is Christmas. It is a gross holiday all over the world, not directly in Moscow, but a lot of Muscovites also follow this holiday. That's why if there are anybody who is involved in this holiday, I give you my best wishes in Christmas. Are you sure that there is nothing to discuss more about the procedure of the exam? Okay, so as a repetition, let me demonstrate you some ECGs. They are about hypertrophy, not of only left sides of the heart, but of right also, But here you can see, have a look, left side hypertrophy. Let's start with the beginning. The rhythm is sinus. Have a look. We have a prolonged line of the fifth lead, V5, and we can estimate P wave before each ventricle complex. We also can see that P wave in its amplitude is a little bit more than normal and a little bit wider than normal. So we can suspect hypertrophy of both atria here. Speaking about hypertrophy of the left ventricle, we can see high R waves in V6, extremely high in V5. Here 10, 12, 12, 27 plus S in V1 also very deep. So, or we can, it is more than 20 here. It is more than 35 if we summarize R in V6 and S in V1. So hypertrophy of the left ventricle is present. Moreover, or we can see changings in ST segment in the main leads. So we can speak about diffuse signs of ischemia. And we can see them also in the left chest leads. Maybe severe hypertrophy of myocard of the left ventricle corresponds with ischemia of this zone. Let's discuss this clinical case. Also, we have a prolonged fifth chest lead where we can see P before each ventricle complex. So it is sinus rhythm. In the second standard lead, the best lead for evaluation of P wave, we can see that it is very high in its amplitude, more than R. R here is very small, and enlarged in its duration, not only in amplitude. Or we can suspect hypertrophy, first of all, of right atrium, and suspect the presence of hypertrophy of left atrium also, but right in the priority. And speaking about hypertrophy of the right ventricle, we also can see ECG signs of it. R amplitude in V1 plus amplitude of V6S waves are more than 10.5 millimeters. So we can speak about their hypertrophy of the right ventricle, of myocard of the right ventricle, which often is due to lung heart formation, due to chronic pulmonary diseases. It may be COPD, bronchial asthma, pulmonary fibrosis, any. Again, we can see right atrial enlargement in this ECG. Left ventricle hypertrophy with enlargement of R in left chest leads, and deep S in right chest leads. By the way, the quality of the photo is not high, but if you look attentively, you will see that P wave is prolonged here, and it may be hypertrophy of left atrium also. The example again of hypertrophy of left ventricle, sinus rhythm, just sharp P, typical for hypertension of hypertrophy, of right atrium, and hypertrophy of myocard of left ventricle. Have a look. The summary of amplitude is more than 35 here. The same we can constatate at this ECG. If you look here, S is very deep, though R is not so severely enlarged, but still. And the hypertrophy signs of hypertrophy of both left and right atrias. Again, hypertrophy, you can see, but the rhythm is not sinus. It is atrial fibrillation. Have a look at the prolonged line. You may see that RR distances are not equal. Ventricle complexes beating are not regular. And we can't find a single P wave before each ventricle complex. It is very common in case of atrial fibrillation. So 2 ECG sciences are enough for estimating of atrial fibrillation, not regular ventricle beatings or different RR distances, and absence of P waves. A single P wave in front of each ventricle complex. Sometimes you may see waves instead of one P, some waves. Sometimes you may not see them. Also, there are signs of hypertrophy of left ventricle, high R in V6, and very deep S in V1. They are, in summary, will give more than 35 millimeters. Okay, colleagues, it is necessary to see ECGs because in your MCQ you may find the description of some peculiarities of ECG. For example, if P wave in the second standard lead or in V1 is too sharp and enlarged in amplitude, which sign it may be? You will answer that these are ECG signs of right atrium hypertrophy. Okay, and now I would like to show you some episodes from the presentation I have given to you previously about bowel problems. Do not forget about Bristol stool chart. The question may be about which chart is suitable for estimation of stool type. At this question, you will answer Bristol stool chart. You may be asked about the goals of direct examination of abdomen of any part of the patient, but also of abdomen. Do not forget that palpation of abdomen are of two types, superficial and deep. Please do not forget about abdominal percussion, which normally gives tympanites, but above liver, above spleen, the sound will be dull because it is very big, there are big organs, and that the auscultation of abdomen, first of all, has the goal to identify the intestinal and bowel motility, so to auscultate the intestine and the bowel sounds. I recommend you to revise the percussion steps one by one of abdomen and the zones of tympany and dullness in case of ascites. According to the physics law, water goes down and the dullness may be percussed here, and tympany sound due to some air in cavities, in abdominal cavity and in bowels, will give tympany sound, except the zone of spleen. If we look at the person with ascites who is standing, again, according to the physics law, water will go down and we shall percuss dullness here. If we ask the patient to lie down and turn to the side, the dullness will go together with water down. So above will be tympanate, here will be dullness sound. Please revise the liver sizes by percussion. Do not forget about extra gastroenterological tract sciences like changed nails, Dupuytren, pulmonary erythema, Nevi spiders. Don't forget about them. And also do not forget about liver encephalopathy as a result of intoxication because of liver failure and the impossibility of liver to perform detoxification procedure. These are Dupuytren contracture. And one of the sign of liver encephalopathy will be flapping tremor. Flapping tremor. If you ask the patient to put the tongue out of the mouth, you will see the flapping tremor of the mouth also. Sorry, of the tongue. Spider nevi. Xanthelasmus. Enlargement of parotid gland. Peripheral lymphatic nodes, not only here, but of the whole body. You may be asked. I recommend you to revise the zones of the abdomen, better understand where pathological problems are, for example, pain location or tenderness. Very often, hypogastric region, students mixed with epigastric one. Well, I suppose that is all. That is all. You have all the presentations, so you may see them if you feel that you have some peculiarities or you have forgotten something. Once again, I ask you about possible questions. Do you have any of them? No? Okay, so is everything clear about Monday?
Yes.
Very nice. So I shall send you just now the whole information. If there are any questions, please ask me in chat. Follow, please, my recommendations. See not less than for 2 times all the clinical cases. Does everybody have clinical cases for Monday? Are there any students who does not have clinical cases for Monday? No, I see. And according to the attendance, I can understand that maybe other students are tired. I suppose they are not ill. And there are a lot of other problems. I can understand you because a lot of subjects. So for today, our class is over. Then your self training. Look at the letters I have. I will send to you in some minutes, and you're welcome. You may also use my email if you'd like to receive any information. Okay? Okay. So, colleagues, goodbye for today. See you on Monday without any stress and additional nervousness, please. Quietly. If any other teacher comes to our Zoom conference, it is okay. But we with Dr. Biketov know you perfectly, so do not worry. Absolutely do not worry. I suppose everything will be quiet and gentle. Goodbye for today. Goodbye for today. My best wishes to everybody, and especially for those who has a holiday today. Merry Christmas. Goodbye.
Thank you, Professor.
Goodbye.